Recording has started. Good morning, Dr. Wu. I think we're ready. I'm Dr. Tuan. I'm the neuromuscular guy at the University of Louisville. I think if
Hello.
you are ready and you can introduce yourself and we can get started.
Okay,
Thank you.
very good. Thank you. So my name is Tuan Vu. I'm a professor of neurology at the University of South Florida. I graduated from Penn State College of Medicine, and I did all my training, fellowship, and residency at Columbia University in New York. Currently, I'm running the neuromuscular division here at USF and also the ALS clinic. Thank you for this opportunity to talk to you about anti-acetylcholine receptor antibody positive generalized myasthenia gravis. That's a mouthful, so I'm going to refer to it as seropositive MG from here on. This program is sponsored by Alexion. This is their slide deck, and I'm obligated to present what is on in the slide deck. So the purpose today is to talk about myasthenia gravis and also the natural course. I will review the pathophysiology of anti-acetylcholine receptor antibodies, generalized myasthenia gravis, and we'll talk a little bit about the burden of disease and symptoms related to the so-called refractory GMG. Here's sort of a vignette of what a typical myasthenic patient would look like. The disease affects women about 60% of the time. And for women, there's a bimodal distribution with the highest peak, and the first peak is between 20 and 30 years of age. And then women have the second peak later in life, roughly around 60 to 70 years of age. And then for men, the peak is after age 50. So normally you see a young woman who the first symptom is usually ptosis and diplopia. And then most people ignore it because they think that maybe it's just, not sleeping well enough. But eventually other symptoms develop, and that's when they seek neurological attention. MG is a chronic autoimmune neuromuscular disorder, and basically is related to the dysfunction at the neuromuscular junction, leading to impaired synaptic transmission and fatigable muscle weakness. Like I said, usually affect the ocular muscle first, but it then can spread, and about 75% of the patient actually progress from just purely ocular to generalized symptoms, with other symptoms like difficulty with swallowing, chewing, breathing, and walking. So once you develop symptoms, about 1 out of 5 will progress pretty rapidly to generalized symptoms. And within a year, most of them, 88% or so, will generalize. The disease is characterized by fatigable muscle weakness. This is a weakness that increases with severity and effort. And that can be challenging. Someone can come in and complain of weakness, but on isometric examination, the strength can be pretty normal, except they can't sustain that if you repeatedly ask them to contract. The course is also variable. So again, that sometimes led people to think that this may be a conversion disorder where one day they'll be normal or near normal, and then the next day severely affected. Several factors can affect the severity of symptoms. So stress, certainly, infections for sure, heat, and that's actually decrease the efficacy of synaptic transmission. So when the patient have a fever, or if they live in Florida in July, they often have exacerbated symptoms. I have a few patients who the symptoms will get worse around their menstrual cycle, and medications, like if they get treated for some sort of infection with certain antibiotics, that can certainly worsen the disease. We have a cancer center down the street, so some of the drugs they use, like the checkpoint inhibitors, can certainly cause myasthenia gravis. So those are the things that we look out for. So within 6 months of onset, about a third of them will reach their maximum weakness. About 2/3 will reach that point in a year, and by about 2 years, 83% of them will reach the maximum degree of weakness. We use these two scales to measure progression and level of function. So the ADL is probably more applicable to general practice. It is a 8-question item measures where you ask them about how they're talking, chewing, swallowing, breathing, limb weakness, double vision, and ptosis have affected their daily routine. The key here is that you have to ask them, since the last visit, how have you done in terms of these functions? If you don't specify that, they'll default to the worst ever, and that the score never changed. This is something that we have a form for, and we give it out to the patient in their waiting room. They can mark it off, and then when they come in, basically you have your history, and you can elaborate on different points at that point. There's a couple of things about this form that's kind of come into play recently in the research arena. This is basically the primary endpoint, change in ADL, for most, if not all, of the clinical trials, mainly because the FDA wanted to have a patient-centric measures rather than something that's more objective. So this is purely subjective. The patient is reporting this to you. And currently there's a consensus that if you have 2 points improvement, that is considered clinically significant. My problem with that is that 2 points is not always 2 points. So let's say, take talking, for example. If you have a 3, a difficulty with understanding, for people to understand you, and you go down 2 points to 1, intermittent slurring of speech, that's an improvement, but you can still function reasonably well with difficulty, to understand speech. However, you go down 1 line for chewing, a 3 means that you're using a gastric tube for nutrition. And if you go down to a 1, you have now fatigue with solid food only. That's a big improvement in function. And I would argue that's more of an improvement than, let's say, going from a 3 up in terms of talking to 1. And the other concept that we're using is minimal symptom manifestation or status. And that's defined as having a ADL score of 0 or 1. If you go from a 9 to a 0, 1, you're basically normal. However, again, some people can have a pretty normal daily routine without having a 0 or 1. For example, you can have a 2 if you have daily but not constant ptosis or diplopia. And if you have really chronic patients, the eye symptoms are always going to be there, and no matter what you do, and so they're never going to reach the MSE or MES status. The definition is not perfect, but that's what we use. A lot of studies use minimal symptom state as an endpoint. A more objective measure is the Quantitative MG Scale. This takes about 30 minutes to perform, and you require to have a spirometry device, also the dynamometer, and so that costs a few $1,000 plus 30 minutes of your time. So people don't use this in clinical practice, but we use it very often in research. In fact, it's usually the first secondary endpoint that we use. And the score go from 0 to 39, and likewise with ADL, the closer you are to zero. In fact, in any scale that we use for MG, and the closer you get to zero, the better you're off, the more normal you are. So the first thing that we do when we suspect MG is to do the antibody testing. To just here, the point here is that, she had some trouble with chewing soft food. She has diplopia and ptosis and some limb weakness. So if she have a point for each of those 4 criteria, she get a 4. And then the QMG is 7, which is fairly mild at this point. In terms of diagnosis, there are several tests that are available. So the first one is the Anti-Acetylcholine receptor antibodies. This usually is confirmatory. However, is not present in everybody. If you have a generalized form of MG, it's about 85%. If you have ocular, purely ocular, it's roughly around 50 or less. So if you have no antibodies, doesn't mean that you don't have MG. And sometimes, it's lab dependent as well. Some labs are way more dependable than others. In terms of bedside assessment, nobody does etrophonium tests anymore, mainly because we actually can't get etrophonium. The only company that makes it stopped making it like at least 5 years ago. So people revert to the ice pack test. If you remember earlier, I mentioned that heat certainly decrease efficiency of synaptic transmission. So what you do is, if somebody have ptosis, you can put an ice pack on the eye for 5 minutes and see if the ptosis would resolve. Electrophysiologically, you can use repetitive nerve stimulation. Unfortunately, the sensitivity for this test in generalized myasthenia gravis has been reported to be between 30 to 80%, and it depends on what you do. If you do more proximal, like facial or trapezius muscles, you tend to have more sensitivity than, let's say, a limb muscle or distal limb muscles. In ocular myasthenia gravis, that sensitivity dropped to between 10 and 30%. Single fiber electromyography is not done everywhere for the simple reason it's time consuming and is really poorly compensated. So people who are not doing it, the needles that you use are also very expensive, and you have to sterilize and all that. So, and there's people who have to do this now using concentric needles as well. The sensitivity is great. It's estimated to be between 0.8 to 0.99 in terms of sensitivity, but specificity is really poor, around 0.17, because single fibers EMG can be abnormal in a variety of neuromuscular diseases like ALS, certain type of myopathy, certain type of neuropathy. So as I mentioned, for the generalized myasthenics, you detect anti-acetylcholine receptor in about 85% of the cases. That leaves about 10 to 15% with so-called seronegative MG. Of this group, about 10% or so would have the MuSK antibody. Another 1 to 2% would have the LRP4 antibodies. That will still leave you about 3% with no detectable antibodies. I want to switch gear and talk about the complement system, and mainly because this is the mechanism by which the anti-acetylcholine receptor antibodies cause muscle damage. So the complement system consists of about 40 proteins in the plasma and on-cell surface. It's called complement because it was discovered as a component of the serum that complement the ability of the antibodies to kill bacteria. It plays an important role in the innate immune system by augmenting the antibody responses, clear the immune complexes, and involved in the process called opsonization, where once the antibodies is bind to the antigen, it draw in phagocytes, leading to phagocytosis, and complement C4b and C3b proteins are involved. It also generated an inflammatory response and causing direct lysis by the formation of the membrane attack complex, or MAC. And I'll talk about that in a second. So if you go back to the oral antibodies, they are predominantly of the IgG classes, but they are of different IgG subclasses. So for example, the anti-acetylcholine receptor antibodies are predominantly IgG1 subclass and IgG3. And both of these subclasses cause problems by activating the complement systems. The LRP4 is also IgG1, even though it said unknown here. LRP4 actually does activate the complement system as well. And if you look at MuSK antibody, it's IgG4 subclass. It does not activate the complement system, but it acts through a different mechanism. So here's the complement cascade. There's different type of antibodies. So when you do the anti-acetylcholine receptor antibodies panel, there's three values that usually come back. The first one is blocking, meaning that the antibodies bind to the receptor, blocking these small dots, the acetylcholine molecule, from binding to it to elicit a end plate potential. And then you have the so-called modulating antibodies, where the antibody binds to receptors, and then the whole complex is internalized and removed from the surface. And then the most common type is binding antibodies. This is the antibodies that, when bind to the receptors, that would activate the complement cascade. And so when it binds to the antibodies, you would have the C1 complex formation that then convert to C3, C3 then get converted to C5. C5 then split into C5a. C5a is actually a pro-inflammatory molecule where it attract inflammatory cells and cause the release of cytokines that cause local inflammation. C5b then form a complex with C6, C7, C8, and multiple molecules C9 to form this membrane attacking complex. Basically, is causing a hole in the cell walls. This is how we fight encapsulated bacteria. Basically, it bore a hole in this membrane and cause lysis of the bacteria. So in Myasthenia Gravis, here's a normal situation where you see these receptors sitting in the postsynaptic membrane that has a lot of folds and increasing the surface area. So when the antibodies binds to the receptor, you have this complement cascade that lead to the MAC formation, and as a result, the membrane become damaged or destructed. And you can see on this cascade here, the black dots are the deposition of the C9 component of the MAC, and you can see the membrane become a lot more simplified, and you lose the foldings and all that. So in a healthy situation, whenever acetylcholine binds to the receptors, you have a miniature end plate potential, and when you exercise, the release of acetylcholine actually decrease over time, because it takes a while to replenish the packages of acetylcholine. But in a normal situation, you never get below the threshold to generate an action potential. So you're always going to have a muscle contraction when you tell the muscle to contract. In MG, what happened is the postsynaptic membrane is damaged. You lost receptors. So when initially, when you release the initial quanta of acetylcholine receptor, acetylcholine, and as they bind to the receptor, you may generate a mini end plate potential, but as you exercise, the amount of acetylcholine release go down, and at some point, you're not going to activate enough receptors to cause a action potential in the muscle, and therefore your muscle doesn't contract, and that's perceived as weakness. Back to Janet, she continues to progress, and so it brings us to the point of refractory MG, which occurs in about 15% of the patients. These are the patients that failed to respond to therapies, or couldn't tolerate what you are giving them, and because of the persistence of symptoms, they continue to depends on really high dose of whatever you decide to use, and that can cause some intolerance or adverse events that prevent you from trying to get a better hold of the symptoms. In some studies, these patients would, 70% of them would have limb or truncal issues, and then about 40% would have trouble chewing or swallowing. The persistent symptoms certainly will impact people's activities and lives, because of the fact that you're feeling tired all the time. You're not going to feel good. I mean, if you're on call and stay up all night, the next day your quality of life is not really great. It's also a social disadvantage. Imagine, you're asked to attending a barbecue or a birthday bash, and you know that you're not going to last the whole night, and so you're going to say, you know what, I'm a little bit tired, I'm going to stay home today, or leave early. And then because you're poorly controlled, you may have exacerbation and crisis. So the difference between exacerbation, of course, is worsening of symptom versus crisis, which require respiratory support. And so here, how there's statistics about how MG can impact your life. These patients tend to have higher MG-ADL score. They tend to be hospitalized, come to the ER more often. They tend to be going into crisis more often, and likewise with exacerbation. And that has a significant impact on your quality of life as well as your employment. I mean, if you look at us, for example, if you are out for a day, that put a burden on everybody else, and when you get back, there's a lot of things to catch up. For people who have severe MG, half of them will lose their job, or half of them have to, so roughly about half will either lose their job or have to cut back considerably. And if you can't support yourself, that's also impact your emotional and social status. So basically, that's the end of the slideshow. I'm going to open up for any question that you may have at this point. And thank you for your attention.
Thank you, Dr. Vo, for your excellent presentation. I have a question about actually in the practice to take care of myasthenia gravis patients. If you get a severe generalized myasthenia gravis patient with positive anti-acetylcholine receptor antibody, do you usually start the IVIG or something else first?
Assuming they're already on immunosuppressants?
Yes, yes. My question is, this granule was arranged by the company who produces Cereris. So my question specifically, do you usually try IVIG first, or you will start Cereris before IVIG?
So the first point is people use IVIG all the time. but IVIG has not been proven to be effective in the maintenance of myasthenia gravis. It's used very routinely to rescue, and we know that it works. People also, use IVIG as maintenance therapy, and we actually did a study a few years ago where it was a failed study, not because it didn't work, but because the placebo effect is so high. So if you use eculizumab, what happened is the study was designed for so-called refractory patients, and so you have to fail 2 medications or IVIG plus another medication for a year prior to entry. And what happened is now a lot of insurance companies will require you to fulfill those criteria. So you often cannot use eculizumab until you show that you fail those criteria. So sometimes we have to go through IVIG to get the eculizumab. But I mean, but personally, if I can get eculizumab, there's no reason to go straight through to IVIG. Eculizumab actually protects the postsynaptic membrane, so that's a plus. And also, it works really quick.
Thank you.
Thank you very much. This is Robert Friedland.
Hi, how are you?
Very good. Thank you very much for your comprehensive presentation. Could you please comment on what is the cause of myasthenia?
That's we actually don't know. So, what happened is we don't know what the antigen that's doing that. So, basically, you have immature T cells that go to the thymus, and that's where basically that's a training camp. So they would be sensitized to different antigen, and normally, if they are self-directed, they get eliminated. Occasionally, they got through, and so once they get through, they activated B cell conversion to plasma cell become long-living, and then start producing antibodies. So that's the mechanism of action, and people think that it's because the self-screening mechanism in the thymus is malfunction, and that's why thymectomy is the method by which we can treat MG as well.
Thank you. With Dr. Rulan Liu here in Louisville, we found that with a blast search, there is a period of homology, 6 amino acids that are identical for the acetylcholine receptor and a virus of plants called turnip mosaic virus.
Right, yeah, I've heard about that, yeah.
And it has not been comprehensively investigated. And we are exposed to plant viruses through our diet. And this could explain several interesting things about myasthenia.
For sure, yeah, that's actually an interesting point.
And I'd be pleased to share the blast search with you. I could.
Oh, absolutely. If you wouldn't mind, if you wouldn't mind sending it to me.
Thank you.
Thank you.
Thank you for this presentation. I have a question about whether there's any sort of molecular markers that you notice consistently in patients with myasthenia gravis who are refractory or who go on to develop seemingly permanent symptoms that do not attenuate with medication. Is there any molecular background to that population that's in common?
I am not, to be honest, I'm not aware of any. I know that Alexion looked back at all the samples that we collected in the studies to look for these things, and as far as I know, there hasn't been anything published from that work.
Thank you.
Hi, good morning. I had a question. This is Dr. Shah.
Hi.
How often do you use the Soliris for just ocular myasthenia, if anything, if the other immunosuppressants are not helping?
The trouble there is that the study, the REGAIN study, exclude purely ocular patients, and so it's usually not approved for purely ocular myasthenia gravis, and it's hard to get it approved by insurance company for that purpose. However, there's a paper published a few years back from long-term study, and it showed to have some effect.
Okay.
I have to, if you can ask Wade to send you that paper, but there seems to be some effect.
So
But the problem here is to get the insurance to approve this product.
But you would usually stop the Imuran or the Cellcept or the IVIG before switching to Soliris, or do you bridge both?
I bridge. I mean, in the studies, you have to stop them. If you were on IVIG or plasma exchange, you have to stop it at least 4 weeks before screening, and then you keep everything the same. Sometimes that's a challenge for really severely affected patients. So in clinical practice, you normally start, give them the last dose of IVIG, and then start Soliris, and then see how they do. So the effect of eculizumab is observed within a month. So usually by about 2 weeks in the study, by 2 weeks in, you see a separation between placebo and treated. And then your IVIG usually lasts 3 weeks to a month anyway. So if you give them a dose IVIG and then start, at least you have some coverage. You can also argue that if you give them IVIG and you give them a monoclonal, they may be eliminated faster because of the competition at the FcRn. But that's what I use, and I usually get away with it.
Thank you.
Hello, doctor. This is Fernando. I was reading that rituximab is a very good treatment for myasthenia gravis with patients who have the most receptor antibody. So my question is, should we use the therapy initially or as a second-line therapy?
For MuSK or for anti-acetylcholine receptor?
For the most, doctor.
Yeah. So for MuSK, I think that's the standard treatment. I think that seems, in my experience anyway, it seems to be more effective than anything else we use.
Martin Brown, thank you for the talk. It was great. It's always good to hear from another neuromuscular specialist. The risk of meningitis, bacterial meningitis, has been a concern for some of our patients, and so I kind of want to know, what vaccine do you recommend for meningitis? And since these people are generally, they're immunosuppressed, how do you know that the vaccine has worked before you start them on Soliris? Okay, so you need to vaccinate them ahead, at least 2 weeks prior to initiating treatment with a tetravalent and also type B. So for tetravalent, I use Menactra, and for type B, I use Bexsero. You can also use Tremenda, but that's a 3-dose vaccine. So for Menactra, you give them the first dose 2 weeks prior to treatment, and then the booster is 2 months or later, and the same way with Bexsero. And then I think for the tetravalent, you have to boost them within 2 years. The guidance for the other one is not so clear. In the REGAIN trial, a lot of these patients come in with immunosuppressants, and in that study, there was no meningitis during the
initial placebo-controlled study. After the study closed, after the open label extension study closed, which is about 3 years after, there was one case of non-fatal meningitis. The medication has been around for a long time to treat a few other conditions. And what we found is that before type B vaccination came around, the high incidence of meningitis was higher. With the type B vaccination, it's pretty rare now to have that.
We're having some difficulty with our patients getting, when they get COVID vaccines, they want to know if it worked, if they are now protected against COVID, and we can get there's an antibody test, I think, from LabCorp. Is there something similar to that to check and see if is it safe? Like, are you protected? Do you have a measurable titer of Neisseria antibodies, or is there a way to tell if your immune system is prepared?
I actually don't know the answer to that one. We never checked. And they carry a card to tell them if you have, these symptoms, stiff neck, fever, headaches, to go to the ER and get evaluated. But I don't think there's no guidance regarding checking, the immune status.
Also, go ahead.
Go ahead.
Oh, so on the we've never been able to do tensilon, like you said, it's no longer available. And so we very frequently will use pyridostigmine, which has become available in IV form in the past 10 years. Have you tried using pyridostigmine as sort of a modified tensilon test for diagnostic purposes?
I have not, but that's actually not a bad idea. I mean, the effect lasts a bit longer, so,
Right.
I guess you have to observe a little bit longer, but no, that's a good idea, though.
Yeah, just keep them closer to the bathroom.
Yeah.
And keep the atropine handy.
Yeah.
I have another question. During the pandemic, a lot of patients are concerned by using, immunomodulating treatment. And I got several patients, I like to switch to complement inhibitor, like Soliris.
Right.
But they rather stick with IVIG for now. I say IVIG, probably they might get an antibody against to the COVID. So do you have any cases, or do you know anything about the complement inhibitor can increase risk of infections, including COVID?
Not that we know of. It's funny because complement inhibitor was used in a trial to treat COVID. The result is still out there. I think I haven't heard of the reported yet. But during the time of COVID, we actually did another complement inhibitor study, and so far the analysis hasn't shown any adverse event from COVID. I think we reported this at the MGFA a couple months ago as an abstract, and the safety profile looks pretty good.
Looks like no more questions. Thank you, Dr. Will, for your nice, presentation, also discussion. Thank you.
Oh, my pleasure. I appreciate the opportunity. Thank you.
Thank you.